This is an adult who presented with acute severe headache, the worst headache of his life. With such scenario, the first diagnostic consideration would be that of subarachnoid hemorrhage, which is seen here. The CSF in the ventricles is dark, and the CSF in the sulci should be as dark as that. Bright, dense blood fills the sulci. A parameter of severity of subarachnoid hemorrhage includes involvement of the ventricles, and that's what you see here as a blood level. The reason I'm showing the case is to remember that subarachnoid hemorrhage is most commonly a result of aneurysm. Of course, hemorrhage of any sort anywhere in the body could be due to trauma. Subarachnoid hemorrhage could result from other non-traumatic causes as well, such as extension of hypertensive hemorrhage. The main reason I'm showing the case is to concentrate on this area here. As you noticed, there is concentration of very dense blood in the interhemispheric fissure in this region. This is also surrounded by areas of less density, and in this case, actually hypodensity. This tells you that this is an acute clot that's surrounded by blood of more chronic age. And this is a hint that tells you that the aneurysm causing this subarachnoid hemorrhage is likely living there. This sign is called the sentinel clot sign. Since this is a non-traumatic case and there is a sentinel clot sign in this region, you suspect that the aneurysm will be located there. This is the expected location of the anterior communicating artery that connects both anterior cerebral arteries. This is the cerebral angiogram after giving contrast on the same patient. Here you see the two anterior cerebral arteries that run in the interhemispheric fissure. And at the region where you expect to see the anterior communicating artery connecting both vessels, you see this thing here. So this saccular outpatching of the contrast is consistent with an aneurysm of the anterior communicating artery. And the aneurysm is indeed seen in what we call the sentinel clot sign on the pre-contrast study. We learned from this case is that when you hear the worst headache ever or the thunderclap headache, think about subarachnoid hemorrhage. Hemorrhage anywhere could be classified into traumatic and non-traumatic, and the commonest reason for subarachnoid hemorrhage is non-traumatic. In particular, when you see a non-traumatic subarachnoid hemorrhage, the commonest thing to look for would be an aneurysm. We've also seen a very neat sentinel clot sign, which tells you that the hemorrhage is likely arising from this area. And this was actually confirmed on the CT cerebral angiogram as an anterior communicating aneurysm. Many other important points to talk about when looking at a case of subarachnoid hemorrhage, and we'll discuss that in future clips. Thanks for watching. See you later. Today's case is a quick show and tell. This is a young patient who presents with cough and fever for 2 weeks. As you see here, the abnormality is seen in both upper lungs. Although the changes may be partially explained on the basis of airspace opacities, the main abnormality is in the form of dots and lines, and that's why it's a reticulonodular pattern. So although the predominant abnormality is interstitial, you have airspace opacities or consolidations here. Add to that you have multiple areas of well-defined air lucencies that are consistent with cavities. And if you look with an expert eye, you'll notice that some of these cavities have fluid levels. Sometimes it's easier to see the fluid level than to identify the cavity itself, so look carefully for fluid levels denoting cavities. Looking carefully as well, you notice you have these thick rimmed air lucencies. which may represent smaller cavities, but given the interstitial opacities, these could be bronchiectatic airways with thickened walls. Here you see the same appearance on the right side. This is likely bronchiectasis. Since you're thinking about an abnormality that involves the airways, these nodules could represent small inflamed bronchioles. If you do a CT scan, these may represent centrilobular nodules within small airways. So you see a bilateral upper lung abnormality that has airspace and interstitial opacities that is also associated with bronchiectasis and cavitation. The appearance is consistent with an infection, and you have to think about one main differential, and that is TB. So whenever you have a sick patient with bilateral apical cavitary abnormalities, you have to think about tuberculosis. So this was a quick show and tell case. More cases later. Thanks for watching. This is a large amount of fluid filling the abdomen. Now, it's very common to see ascites for various reasons. However, one of the causes of ascites could be malignancy. We have seen before that thick mucinous ascites, whether benign or malignant, could scallop the liver. However, there is no obvious scalloping in this examination. You might think about it when you see regions such as this here. Other features of malignancy that you should look for would include this finding here. There's this soft tissue nodule that is attached to the parietal peritoneum. If you see one, look for others, and here's another one here. If you go lower down, you'll see multiple of these nodules. So seeing soft tissue nodules based on the peritoneum is concerning. Another thing that you'd look for, which is absent here, is obvious thickening of the peritoneum. And whenever you're thinking about malignancy, you have to look carefully at the mesentery and the omentum. To simplify the omentum, it's a folded layer that's located anteriorly and composed of fat. Fat should be similar to subcutaneous fat here, so the omentum should have clean fat. And if you look carefully, this is not the case here. Notice how the omentum is stranded and looks dirty and has multiple nodules. Even more clearly seen, here's a piece of omentum that's displaced with a frank nodule. Such an appearance within the omentum is called omental caking. Since you see a large amount of ascites, omental caking, omental nodularity, and peritoneal nodules, you know you're dealing with a malignancy, so look for a primary. Peritoneal and omental metastasis is commonly due to gastrointestinal or genitourinary tumors. If we scroll all the way down, in this case, you'll find a large pelviabdominal mass. This is your normal uterus, and this mass is adjacent to the uterus in what we call the right adnexa. This is compared to a left adnexa that has a normal ovary. There is always a differential diagnosis for a right adnexa lesion, especially one that looks ugly and necrotic like this. However, what's common is common. This is very consistent with a right ovarian malignant neoplasm. Supportive of this is the presence of omental and peritoneal metastasis. The teaching points in this case is to remember that ascites is a very common finding on abdominal pelvic CT. Remember that ascites could be benign or malignant in nature, so always make sure to look for peritoneal thickening, which is not present in this case, peritoneal nodularity, which we saw. Look for omental deposits and omental caking. And finally, look for a primary malignancy, which is commonly gastrointestinal or genitourinary in nature. Thank you for watching. Don't miss our older snaps on our YouTube and Vimeo channels. See you later.